Hi, ladies and gentlemen, and we are now in the first lecture of last session of pathology. This first lecture would be of Dr. Zulfikar Ali, which is known as Dr. Z. Ali. He has definitely an extensive introduction. Dr. Ali serves as Professor of Pathology and Radiology at the Johns Hopkins University School of Medicine, as well as the Director of Division of Cytopathology at the Johns Hopkins Hospital. He received his pathology residency training at North Shore University Hospital, Cornell University in the New York, with fellowship in oncological surgical pathology at Memorial Sloan Kettering Cancer Center in New York, and cytopathology at the Johns Hopkins Hospital, Baltimore. Known globally as innovative educator, Dr. Ali has well over 360 invited lectures and keynote speeches. Dr. Ali has published extensively with over 310 articles in major scientific journals, over 35 books and book chapters, known for his expertise in thyroid and pancreatic cytopathology. His monograph on Bethesda system for reporting thyroid cytopathology has translated in 18 languages and is extensively used in medical practice all over the world. He is the founding editor-in-chief of Journal of American Society of Cytopathology. His talk would be Building on the Best Bethesda system for reporting thyroid cytopathology 2010, 2017, and beyond. Now over to Dr. Ali.
Thank you so much for that kind introduction. Assalamu alaikum and good morning from here in Maryland, US. It's pre-dawn hours here, and what a pleasure it is to be talking to you live from here. And in this regard, I'm so thankful to the organizers for accommodating my request for a live presentation. So let me share my screen, and then we can go ahead. So I hope it projects all right now, full screen. So what I plan to do this morning is to let you know about the updates that we are trying to make in the Bethesda system for reporting thyroid cytopathology. It's a topic which is very near and dear to my heart, and we are very proud that over the years, the Bethesda system has done very well nationally and internationally all over the world. Before I do that, I just wanted to let you know where I come from. This is Johns Hopkins Hospital. This is our newest addition to the campus. It's a massive campus with over 80 buildings, several city blocks. But still, despite all the newer buildings that we have added, this older building, which is more than 130 years old, with this blue-green dome, is still the symbol of Johns Hopkins excellence. We have been very proud that we are considered one of the best medical institutions in the world. And I can say with pride that it's my 28th year of working at Hopkins. So it has been a very rewarding journey at Johns Hopkins. Before I go any further, another thing I wanted to let you know was this couple of sentences that a very well-known cytopathologist, Leo Koss, and I'm sure most of the audience are familiar with that, his textbook, Diagnostic Cytology, and its histopathologic basis is considered almost like a Bible in cytopathology. And in 1961, many decades ago, he said something which is so pertinent in today's practice, and I'll read. An accurate cytologic diagnosis of disease is both possible and desirable. Therefore, the report should be expressed in simple language that can be readily understood by the clinician. So we all know that what we do on a daily basis when we look at glass slides in cytology or histology and make a diagnosis, that interpretation part is only 50% of what we do. The other 50%, which is equally important, is the way we report our diagnosis using a common nomenclature and a common language, which goes beyond borders wherever we practice pathology or cytopathology. So this is where a universal reporting system assumes so much importance. I'm sure that most of you who practice cytopathology use the Bethesda system. The first one was published in 2010. The second revision was in 2017. And as you can see here, looking at the very simple scheme of reporting, there are 6 diagnostic categories with very simple names. But one thing which is unprecedented was that despite the fact that in 2007, we had a consensus meeting at the National Cancer Institute in Bethesda, which is a town in the state of Maryland and has the name Bethesda System, we could not agree on single names for the 6 diagnostic categories. So as you can see here, in 3 of the 6 diagnostic categories, there are 2 names: non-diagnostic or unsat, AUS or FLUS, suspicious for a follicular neoplasm or a follicular neoplasm. And the major reason for that is that there was a group of people who favored one or the other category. And in order to be completely inclusive of everyone's opinion, Dr. Sebas and I decided at the end that we will endorse both names, but strongly recommend to individuals and laboratories that they should only use one or the other name. Don't use them interchangeably. But despite the strong recommendation over the years, I've realized that there are certain hospitals which use these terms interchangeably that added to the confusion of using Bethesda system to some extent. And I'll tell you what we are going to do in the 2023 edition, which is the 3rd edition. The other thing which you would notice here are there are no numbers written before these 6 diagnostic categories, because Bethesda system was never meant to be a numerical reporting system. It has these beautiful, simple names, and we always wanted people to use these proper names. But over the years, once again, we started to see a lot of people would say Bethesda 1 or Bethesda 5 or Bethesda 6, which to us is wrong. And we strongly recommend that if you use numbers, also be in a habit to maybe in parentheses write the actual names of the diagnostic category you are using. So the success of the Bethesda system is because it was built on a framework of what we call probabilistic approach, meaning the risk of malignancy is implicit in each of the 6 diagnostic categories. And that is very helpful to the clinician because they know exactly what would be the chances of encountering a malignant tumor when the resection is done. And also, since it was a multidisciplinary approach when we created the Bethesda system, with a complete input by endocrinologists, head and neck surgeons, radiologists, everyone was involved with creating the Bethesda system at NCI. And hence, everyone knows when you call something benign, patient needs a simple follow-up. When you call something follicular neoplasm, patient need a lobectomy, so on and so forth. So that is the main reason why it became so successful. So in 2017, in 2016 in Yokohama, the International Congress of Cytology took place, and that's where we discussed the possibility of revising the Bethesda system, and hence you got the blue book in 2017. We revised the risk of malignancies. The one in 2010 are given in black. The revisions are in red, and as you can see, based on prospectively analyzed data, the ROMs were significantly revised, 5 to 10 for non-diagnostic, 10 to 30, so on and so forth. And also for the first time, we started to see the inclusion of molecular testing in the diagnostic workup of these patients at the time of fine needle aspiration. And hence, for AUS FLUS, molecular testing was recommended. For follicular neoplasm, molecular testing was recommended. And also from the clinician's point of view, a more conservative approach was practiced. For example, in the American Thyroid Association guidelines, which are the guidelines followed all over the US and abroad. As you can see, one of the recommendations, 35B, clearly states the patient with well-differentiated thyroid cancer, which is 4 cm or smaller and node negative with no extra capsular extension, patient can benefit from lobectomy. So all these things were duly included in the 2017 Bethesda. So then later on, after the publication of 2017, several years down the road, we realized several factors, such as now we have even newer data based on prospectively analyzed studies. We have new molecular tests, and the existing molecular test had a much more wider menu of offering more mutations and more elaborate testing. The American Thyroid Association guidelines are coming out later this year or early next year, and we wanted to incorporate that in any forthcoming revision. WHO came out with new terminology just a few months ago, and we wanted to incorporate some of the changes that the WHO was recommended. And for the first time, we made an effort and we wanted to get rid of the double names in the three of the six diagnostic categories. And I'm very happy to say that due to my own personal efforts also, we for the first time agreed that will get rid of the double names in those three categories, and I'll show it to you in a minute. Although Bethesda system was always a global reporting system with multinational authorship, we wanted to increase that this time, and hence all these factors were taken into account when we decided to write up the 2023 Bethesda system. Some of you might be traveling to Baltimore in about 10 days' time to attend the International Congress of Cytology, which is on the 15th of November. It's a huge event because for the first time it's combining and it's a conjoined meeting with the 70th annual meeting of the American Society of Cytopathology. So it will be a huge event. And at that particular Congress, I will be moderating a special state-of-the-art session, which is entitled Quest for Perfection, Updating the Bethesda System for Reporting Thyroid Cytopathology. And I would be presenting along with several other experts who are involved with the book, the specific updates that we are making in the Bethesda system. So just to give you a sneak peek, it will be called the 2023 edition. The third edition, I have a new co-author, Paul Wanderland. Dr. Ed Sebus will not be on the book, some personal reasons. He is taking life easy, and he expressed that he would not want to be on the book. So Paul and I will be the editors. Since slightly expanded edition, I wanted to add associate editors, Zubair Baloch from University of Pennsylvania, Beatrix Cochamp-Roulier and Philippe Viel from Paris, France, and Fernando Schmidt from Porto, Portugal, all very well-known thyroid experts will be associate editors. We will have a complete endorsement by European Federation of Cytology Society, which is a umbrella organization of over 26 European countries. The authorship has been increased to 65 from 44 in 2017. We have more clinicians and radiologists, and hence we have added 2 new chapters, one on clinical implications and imaging findings, and one on molecular testing and ancillary testings. And as I mentioned, there are new risk of malignancies. For the first time, we have added a discussion on pediatric nodules, because we all know that children, when they present with thyroid nodule, they behave differently. They have a much higher risk of malignancy, and hence they are treated much more aggressively. And as I mentioned, we have single names for the 3 diagnostic categories, which used to have a double names. The atypical category, AUS or FLUS, has been simplified this time into just simply 2 subcategories, AUS nuclear, which is the higher grade, and AUS all other, which is the lower grade. And as I mentioned, we are aligning the terminology with the WHO recommendation, and we have a publication date of June 2023, but we are hoping that the book will be out much sooner. So this is how it would look like. Unsatisfactory is out, FLUS is out, suspicious for a follicular neoplasm is out. So it's very simple now, non-diagnostic, benign, AUS, SFM, and malignant, and very easy to use these names. And this is a very important table because it shows you the comparison of the risk of malignancies in 2010 in black, 2017 in red, and the newest one of 2023 in green. And for the first time, we have also included the average risk of malignancy, not only the range, but the average. So as you can see, there is significant change, 2 to 20, from 5 to 10, 0 to 6, 20 to 32, 25 to 50, 50 to 80, or near 100%. And some change in the management algorithm for AUS. Sometimes clinicians now follow it much more conservatively, although repeat FNA or molecular testing is recommended. They may opt for a lobectomy if it's a higher risk, or they may opt for simple surveillance and follow-up if it's a lower risk AUS. For follicular neoplasm, molecular testing is the recommendation, because based on the very high negative predictive value of the currently available molecular tests, you can avoid a diagnostic lobectomy and save the patient from misery of having an unnecessary surgery if the test is negative. For suspicious of follicular neoplasm, although lobectomy is the recommendation, sometimes, or most of the time actually, surgeons take it more aggressively and do a near total thyroidectomy based on a very high negative predictive value, an average of 74%. But we also recommend now, and ATA agrees, that molecular testing should also be done, because now it would not only confirm the diagnosis, because now the molecular tests also have very specific mutational panel, almost near 100% specific. So it will confirm the malignancy in this category, and also based on very specific mutations will also offer the patient chance for personalized or targeted treatments, because now we have FDA approved agents which can be used for these specific mutations. We all know for malignant, it's always near total thyroidectomy, with the exceptions of thyroid lymphoma, perhaps metastasis, or some cases of anaplastic carcinoma where radiation and chemo is used, or lobectomy, which, as I mentioned, if it's a 4 centimeter or smaller, well-differentiated thyroid carcinoma, either follicular or papillary with no nodal involvement or extracapsular extension, the patient can benefit from lobectomy only. In pediatrics, again, as I mentioned, it's significantly different risk of malignancy. So the one in green are for the adults in 2023 edition. The one in red are for pediatrics patients. So as you can see, benign, higher risk, AUS, significantly higher risk, follicular neoplasm, SFM, and malignant, significantly higher. And hence the approach is very aggressive. These patients undergo resection, either lobectomy or complete thyroidectomy, a total thyroidectomy, much more often than in adult patients. So this is something that you will see in the new edition. So we all know that the patient, when he presents with a thyroid nodule, the workup starts with the clinical features, a good palpation, findings, and of course, imaging. And we strongly, strongly recommend, just like in the previous editions, that all thyroid FNAs, regardless of the size, should be done under ultrasound guidance if that modality is available at your institution. And it simply illustrates that that seeing is believing. What you are seeing with the tip of the needle in the nodule is what you would sample. So you assure an accurate sampling. So for example, in this isoechoic lesion, you can see the tip of the needle, which is echogenic, and hence it's very important that you ensure accurate sampling. And also, although complications are rare, but sometimes they can happen. For example, in this ultrasound image with color Doppler on, you can see in between these calipers, there is a large isoechoic hematoma. You can actually see the source of the bleeding vessels, and these patients need simple compression, cold compression, and nothing extensive is needed. So not only you ensure an accurate sampling, you can treat any hematoma formation, any bleeding at that time. And also, there are two other important reasons why you do it in ultrasound. You confirm the presence of the nodule, which was palpated by a clinician, either internist or patient himself. And it's a well-known fact that 1 out of 6 times when you put the patient through ultrasound, you will not find that nodule. It would just be an induration in the gland or something which would be deemed as a nodule. So you once again obviate the need for an unnecessary fine needle aspiration if you cannot locate the nodule on ultrasound. And also 50% of the time, very important for us to understand, 50% of the time when you do ultrasound, you discover other significant findings like 1 or more thyroid nodule, which would be even more pathological on imaging compared to the nodule which was palpated. And also, you may discover cervical lymphadenopathy, which is a significant finding in patients with a thyroid nodule. So I think these are very important facts to remember. And that's the reason that strong recommendation is that it has to be done with the imaging. So you do FNA, you combine it with molecular analysis, and based on a very accurate results, you then subject the patient either to a resection or simply do the clinical follow-up if it's a benign nodule. So I would now address each diagnostic category one by one and selectively only mention the updates. Non-diagnostic, as I mentioned, it's still a significant category because the risk of malignancy is there, 2 to 20%. And hence it's very important for us to realize that these patients should be reaspirated. And the older recommendation was that reaspiration should be done at 3 months with ultrasound guidance, because you want to give patient the chance to heal the trauma of the previous FNA. But that is a wrong recommendation. Several studies have shown over the years, recent few years, that you can bring the patient back at a much shorter interval. So I very commonly get this question that when should we bring the patient back? And my recommendation always is in 3 weeks or a month or 6 weeks, but don't wait for 3 months, because sometimes patient may not come back. So that is something we addressed in 2017 and we'll re-emphasize in 2023 Bethesda. The adequacy criteria remains the same, that 6 groups with roughly 10 cells each, so approximately 60 cells are needed to call something adequate. They can be on one glass slide, several glass slides, one pass, several FNA pass, it doesn't matter. You can even have one large, gigantic group of follicular cells and nothing else, and you can arbitrarily divide that in your mind and count them as separate fragments. In liquid-based cytology, if you use thin prep, a sure path, we all know the cells tend to dissociate, so you may not have fragments. Once again, easy criteria, flexible criteria, you can simply count the cells, 60 cells, adequate FNA interpretation. Practically, we never count the cells. So it's a very rough eyeballing at lower magnification. We assess the cellularity and we call something adequate. We wanted to revise the criteria, make it more flexible, lower the count of cells. Right before we finalized the chapter, we wanted to do that. But unfortunately, we don't have good studies validating what should be the lower number. But in my experience, I very often call something benign and adequate if I have 3 or 4 fragments. I don't go up to the 6th fragment, although officially this is what we are recommended in the Bethesda system, that count 60 cells or 6 fragments of cells. Also very important for us to realize that this only applies to adenomatoid nodule diagnosis. It doesn't apply to cancer diagnosis. It doesn't apply to atypical diagnosis. It doesn't apply to Hashimoto thyroiditis. It doesn't apply to benign FNAs with abundant normal appearing colloid, where you can relax the adequacy criteria and lower it down. Cis fluid-only cases remain a diagnostic dilemma. We all know that they present as these large anechoic nodules on FNA with very thin wall. Anechoic because the ultrasound waves pass through and through, nothing to stop the waves. You get these very black looking, dark looking cyst with very thin septal wall. When you put the needle in and aspirate, you will see abundant hemosiderin-laden macrophages, no colloid, no follicular epithelium, hardly any red blood cells, because the thin cystic fluid would not stick to the slide and you get these big transparent zones. So what to call these cases? Again, the recommendation from us is call it non-diagnostic, but do write a note for the clinician if patient does not have any other risk factors like irregularly thickened cyst wall, microcalcification, mural nodule, so on and so forth. The clinician can consider it benign and adequate. From your end as cytopathologist, you will call it non-diagnostic, cyst fluid only, and then write a note. We all know why it is important for us to do that. For example, in this cystic variant of papillary thyroid carcinoma, it was FNA'd by palpation only. The superficial part was aspirated, which was cyst, the mural nodule, and the large tumor was missed. These are often complex lesions with solid cystic areas. In this case, you see these beautiful punctate echogenic foci, which practically translates into a papillary thyroid carcinoma, which was missed. And hence, it's very important that you do it under ultrasound. So in this case, hemosiderin-laden macrophages, but look at this cluster of cells or a loose fragments of cells with very vacuolated cytoplasm, and giving you an impression that these possibly are histiocytes. But look at the nuclei. They are large and oval with very fine chromatin, and histiocytes don't look like that. So this is a classic cystic subtype or cystic variant of papillary thyroid carcinoma. Look at this particular case. All these cells look like histiocytes because of very finely vacuolated cell cytoplasm. But look at these beautiful intranuclear inclusions. Histiocytes, in my experience, never have intranuclear inclusion. So this is once again a textbook example of cystic variant of papillary thyroid carcinoma. What is the chance of missing cystic lesion of PTC when you have a cystic lesion? I would say 5 to 6% of the cysts do turn out to be cystic PTC. So it's very important that we remember that fact. And these cells are undergoing a simple phenomenon of what we call hypervacuolization of cells, that when you keep or suspend the epithelial cells in a fluid environment for a prolonged period of time, they absorb fluid and they begin to look like histiocytes, these tiny soap bubble vacuoles. But look at these gorgeous intranuclear inclusions. In this case, which was prepared by liquid-based cytology, most of these cells are histiocytes, as you can see here. But these cells have beautiful intranuclear inclusions. So once again, it's a cystic variant of papillary thyroid carcinoma. So unless you're aware of this entity, you will not be able to recognize it. Benign, a great diagnosis with a very low risk of malignancy. 4 is the average in 2023 Bethesda, and these are the 4 conditions that we diagnose. Adenomatoid nodule, the most common one, colloid nodule, which is same as adenomatoid nodule, but has overabundance of benign appearing colloid, Hashimoto, and Graves' disease. And again, these patients don't need any further intervention, simply clinical follow-up with the possible addition of ultrasound if there's any risk factor seen at a yearly or 18-monthly interval. We all know how adenomatoid nodule look like. It's a hyperplastic process, so it will have abundant cellularity. And you will see a bit of polymorphism in architecture and cells. So you have small, intermediate, and large size follicle filled with colloid, some free colloid in the background. Imaging helps because it's a multinodular process, very disfiguring. And very often it would involve the thyroid bilaterally. Occasionally you can see eggshell calcification. So whatever the appearance be, sometimes you see these large, gigantic macro follicles, and when you repeatedly hit them with the tip of the needle, you can disrupt them open, and then you will see these flattened walls in the form of these monolayers of cells, but abundant colloid in the background. Sometimes these cases will only have abundant colloid. And it's in this ultrasound image, you can see a multiseptated lesion, thin septal walls. It appears anechoic, but if you look closely, you have these foci with tails. This is called comet tail artifact. And it happens when ultrasound waves hit a protein-rich fluid in the cysts, such as colloid, and right away, your radiologist can tell you that they are favoring a benign lesion. So basic imaging findings also help in the interpretation of cytology. Things can happen if you're not careful with adenomatoid nodules, such as if you have overabundance of oncocytes, you can confuse it with oncocytic neoplasm, Hürthle cell neoplasm, or if the tip of the needle hits an area with all microfollicles, you may overdiagnose it as follicular neoplasm. Sometimes if it's a cystic component with cyst lining cells with intranuclear inclusions, you can confuse it with papillary carcinoma. If there are reactive metaplastic or degenerative changes, as in this case with beautiful intranuclear inclusion, once again, you can overdiagnose it as papillary carcinoma. And of course, papillary architecture can be seen in adenomatoid nodules. So very briefly, these are some scenarios where you can overdiagnose this as atypical, suspicious, or even malignant, so be aware of these findings. I often show this slide in my talks and to remind people that the most significant cause of a bad diagnosis in thyroid cytopathology leading to overdiagnosis is Hashimoto thyroiditis. So if you're not careful, you can end up like this gentleman. Imaging helps. It's a bilateral symmetrical process as seen on this gross specimen. It's lobulated, microlobulated, because you have all these gray-white lymphocytic nodules, expansion of follicles with this lymphocytic infiltrate, markedly dilated isthmus, which often is a finding on gross examination also. And in the initial phase, it's a hypervascular lesion If you do the color Doppler in the later advanced stages, you may lose the hypervascularity. So all these features help. So most of the time, you and I are lucky. We are lucky, and we see this classic biphasic admixture of oncocytes or Hürthl cells with juxtaposed lymphohistiocytic aggregate polymorphous lymphocytes. They can be seen side by side, or they can be intimately admixed with each other. Now, issues are when you start to see reactive changes in the follicular epithelium. For example, if you look at this particular image, these cells have enlarged nuclei, which are very crowded, disorganized with oval shapes and beautiful nuclear grooves, but the background is lymphocytic. Look at this one, oval nuclei, beautiful nuclear grooves, and look at this nucleus, sharply punched out intranuclear inclusion, grooves, fine powdery chromatin, oval nuclei. Look at these intranuclear inclusions. All three cases on follow-up were benign. They have lymphocytic thyroiditis. So I'm showing you some or all the features of papillary carcinoma and Hashimoto. I'm telling you these are benign cases. And that's what the take-home message is, that if the patient has previous history of Hashimoto, or you're seeing concurrent changes of lymphocytic thyroiditis in the FNA you're examining, have a very high threshold for calling that suspicious for PTC or PTC. Otherwise, you will have a false positive diagnosis to justify. I am not stopping you from making the diagnosis of PTC in Hashimoto. We all know that these patients have higher incidence of PTC when they have the long-standing disease, but still have a much higher threshold. I often call them suspicious of PTC in a background of Hashimoto, or AUS nuclear in a background of Hashimoto, but I only reserve the diagnosis of PTC arising in a Hashimoto when I have several passes with edge-to-edge papillary thyroid carcinoma. We know AUS, when we started it, was a contentious category. It has many faces. These are the cases which have cellular atypia, which is subtle and focal. We don't want to call it benign. On the other hand, we don't want to go to follicular neoplasm or suspicious of malignant and have the patient undergo a lobectomy. And hence we use this term, AUS. There are many scenarios which are listed in the monograph, so I'm not going to show you a specific example, but just to let you know something about the update. We have realized our own study that I published from Hopkins that there are two discrete categories within AUS. When you call something AUS based on nuclear or cytologic atypia, in our study, it was 48% risk of malignancy. When we used all other categories, architectural, and Hürthl cell, so on and so forth, the risk of malignancy was down to 23, and hence there are two distinct groups. This was further proven by many recent studies based on molecular analysis, where they showed that the nuclear one, or the high-risk one, shows a BRAF V600E mutation often. And the ones which are low risk, all other, including the microfollicular, has more often the KRAS, P10, PAX8, PPAR, gamma mutations, meaning leaning more towards a NIFT-P or a follicular neoplasm category. And hence there was every reason for us to revise it. And this is what you would see in 2023 Bethesda, simply two categories, AUS nuclear and AUS other. Follicular neoplasm is a serious diagnosis, and it's often based on imaging finding also. These are oval egg-shaped lesion. This one is isoechoic with very thin capsule, as you can see here. They are typically hypervascular, irregular, nodal vascularity, especially in the middle. Not a very specific feature. These gross specimens show you this one turned out to be an adenoma. You can actually see the needle track with some hemorrhage. This one showed a focal disruption of the capsule, turned out to be minimally invasive follicular carcinoma. And we know that this is based on the capsular vascular invasion with mushrooming of the tumor, a histologic feature not seen on imaging, not seen on cytology. And hence, when we call something follicular neoplasm in cytology, we cannot distinguish adenoma from carcinoma. And hence, you do what is called a diagnostic lobectomy. And if it turns out to be positive, the carcinoma patient is taken back for a completion thyroidectomy. What I strongly recommend now is that when you start to see minor nuclear features in FNA of what you're trying to call a follicular neoplasm, such as oval nuclei, fine chromatin, irregular nuclear membrane, still call it follicular neoplasm. Don't go to suspicious for papillary carcinoma. And the major reason is you want to include all potential cases of NIFT-P, the non-invasive follicular thyroid neoplasm with papillary-like nuclear features, in follicular neoplasm category, because the treatment for NIFT-P is a lobectomy. You don't want to go to suspicious of PTC or PTC because patient may get over treatment with a total thyroidectomy. And hence, in my approach is when I see minor nuclear features of papillary carcinoma, it's a follicular pattern lesion, I downgrade it to a follicular neoplasm, but I often write a note that I cannot rule out the possibility of NIFT-P or even a follicular variant of papillary thyroid carcinoma. So it's very important for all of us to understand that approach. That's how the cytology looks like. You have overabundance of microfollicles, and by predominance, I simply mean that more than 50% of the follicular epithelium should be in a microfollicular architecture with scant colloid or trabecular, and we all know how we define microfollicles. These are rosette-like round structures in the form of a complete circle or near complete circle with 15 or fewer nuclei. So simply, if I would see 50% or more of the follicular epithelium in this architecture, I would call it a follicular neoplasm. Hurthle cell neoplasm, that's how they used to be called. When we use that term, we simply mean pure population of Hurthle cell, near 100%. I don't want to say 70% in histology or whatever criteria you use, but in cytology, it has to be near 100% or 100% of the follicular cells. Just to let you know that in the most recent WHO classification, the word Hurthle cell neoplasm, that term is out. Now we simply call them oncocytic neoplasm, and hence going forward and using the Bethesda system, we will call them oncocytic follicular neoplasm or follicular neoplasm oncocytic type. So this is something which will take place in the 2023 Bethesda. Two features that I often use to favor a neoplasm over a hyperplastic oncocytic process would be the formation of these very fine branching capillary vessels surrounded by oncocytes, or I would see frequent binucleation. If every other cell has two nuclei, then I would favor a neoplasm over a hyperplastic process, especially if they have these macronucleoli. One of the major differentials when you have when you are contemplating follicular neoplasm would be an incidental intrathyroidal parathyroid gland, hyperplasia or adenoma or carcinoma. That's how they look like, smaller cells, more neuroendocrine chromatin, very vascular, a large population of naked nuclei. And when you contemplate that diagnosis at the time of on-site evaluation, be sure to send one dedicated FNA pass. Rinsed in 1 cc of Hank's balance salt solution for PTH chemistry. And if the PTH level comes back next day higher than patient peripheral blood PTH, it becomes diagnostic of a parathyroid lesion. Or you can make a cell block and do a PTH immunostaining, which is a cytoplasmic stain. These days, people do GATA3, which is a nuclear stain, to confirm the diagnosis. You can even take it a step further. If you were asked the question, is this an adenoma or a carcinoma, you can try this newer marker, parafibromin, which is derived from the HTPT2 hyperparathyroidism 2 gene, which is a tumor suppressor gene. And look at the very impressive profile. This staining is lost in a parathyroid carcinoma with a sensitivity of 96% and a specificity of 99%. So this was a real life case. I was asked, could this be adenoma or a carcinoma? So clearly looks parathyroid, had a gorgeous cell block. I do parafibromin, which diffusely stained, and I was able to tell the endocrinologist it's a benign parathyroid tissue, either hyperplastic or adenoma. So finally, this indeterminate thyroid FNAs, where we cannot tell the clinician whether it's benign or malignant. We use the term atypical, very frustrating diagnosis. Almost up to a third of thyroid FNAs are indeterminate. Majority, unfortunately, are still resected. And majority turn out to be benign on resection, either AUS or follicular neoplasm. And we all know the introduction of commercially available molecular tests tests. They started to come in 2014 or 15 and 16. Now they're very popular. There are several tests which are done in the US. The one which we do at Johns Hopkins is the newer pharmacogenomic sequencing classifier, or GSC. These days, they add another layer of testing with the positive mutational panel called Expression Atlas. ThyroSeq is another test. ThyGenNext or Thyramir, which is a microRNA test, is another test. Whichever test is used in your labs, in case they are available in Pakistan, keep on using them. They're all good with very high negative predictive value approaching 96%. And the important thing for us to realize is that these tests are here to stay. They do increase preoperative diagnostic accuracy, and they work in tandem with the FNA test. As you can see, FNA plus molecular test. So when they were introduced, people were very worried that just like HPV testing and PAP tests, it will steal all our FNAs of thyroid away from us, and we will be working for food elsewhere. But this thing will not happen. And I very laughingly tell people that the good thing for us is that these tests are very expensive, and they will not be offered to all patients regardless of the FNA diagnosis. They will only be done when you call something atypical or suspicious. In the US, these tests cost $4,500 or above. And hence, it's very important that we always have FNA of thyroids. And based on our excellent diagnosis of AUS or follicular neoplasm or suspicious for malignancies, these molecular tests will be done. But it's a good thing for us to accept them, that they are here to stay, and also recognize their importance, because they do reduce the amount of so-called diagnostic lobectomies, which are otherwise performed on all atypical diagnoses. Suspicious for malignancy, again, no major change, slight revision in the risk of malignancy. I often add a note in my SFM diagnosis, if I'm calling it suspicious for papillary thyroid carcinoma, that some of these cases may turn out to be NIFT-P, and I strongly recommend that please do lobectomy only. Don't go to total thyroidectomy, because these patients may simply have NIFT-P. So these are nice examples of what you would call suspicious for malignancy. Hypercellular, significant pleomorphism, large oval nuclei, very fine chromatin, beautiful grooves and some intranuclear inclusions, but these are all follicular pattern lesions. They were called suspicious for malignancy, but turn out to be on resection NIFT-P. And hence it's very important that if you have a follicular pattern lesion with focal features of papillary carcinoma, downgraded from suspicious of papillary into follicular neoplasm category, but write a note that it could be a NIFT-P or a follicular variant of papillary carcinoma. But if you called it a follicular neoplasm and it's a NIFT-P, excellent diagnosis, because the treatment of NIFT-P is lobectomy. It's not total thyroidectomy. So again, take home message, follicular pattern lesion with focal nuclear feature, think of NIFT-P, downgraded to follicular neoplasm, and have a good understanding that NIFT-P cannot be diagnosed on FNA. It's a histologic diagnosis. Malignant, again, as we make 100% of these cases do turn out to be malignant papillary carcinoma and subtype. Now WHO calls it subtypes, not variants. We usually recommend that you should rely on the major diagnostic feature of PTC, like papillary architecture pseudomorph body, something which is only seen in 20% of the cases. But in all other cases, think of adding this optional note that 3 to 4% of all cases which are diagnosed as papillary thyroid carcinoma and FNA turn out to be NIFT-P. This is to protect yourself, your clinician, from any legal issues which can arise down the road, because NIFT-P sometimes is a very troubling diagnosis. We also diagnose medullary and plastic metastasis, all these entities. So again, for PTC, which is the most common diagnosis, malignant diagnosis you and I make on a daily basis, starts with imaging. This one is a capsulated lesion with beautiful, bright echogenic foci, which translate into clusters of pseudomorph bodies of microcalcification. The most specific, but not a very sensitive imaging finding of papillary carcinoma. You see beautiful fibrovascular core in this papillary architecture lesion. But the real diagnosis depends on going on 40x magnification, because then we can see these beautiful intranuclear inclusions, oval nuclei, longitudinally running grooves, tiny marginal nucleoli which sit underneath the basement membrane. So classic appearance of papillary carcinoma. How about the variants or subtype? I don't routinely recommend that people do that, but if you have an aggressive subtype like these examples of tall cell variant, and these two are from columnar cell variant, you can suspect that and mention it in your report. So papillary thyroid carcinoma, in a note, you can say focal features suggest tall cell variant or hobnail variant, or in this example, for example, columnar variant. This sometimes helps the clinician. Often surgeons take out the paratracheal, central, or level 6 lymph node prophylactically, but sometimes good surgeons would not unnecessarily take these nodes out, which are very commonly involved with papillary carcinoma. So they will only take these nodes out if they can palpate the lymphadenopathy or the imaging shows involvement of the node. But if both these are negative, but in your diagnosis, you mention an aggressive variant, then they can do a sentinel lymph node dissection. So that's the only importance. But routinely, I do not recommend that people subtype their papillary carcinomas. These are examples of medullary carcinoma, an easy diagnosis, but keep in mind that this is one of the thyroid tumors with the longest range of morphologic variations. Sometimes you can have plasmacytoid or epithelioid, shown here. Sometimes you can get spindle cell. Look for amyloid and try to recognize it accurately, because in my experience, 60, 65, 70% of these cases will have amyloid. Problems typically arise when you have these uncommon subtypes, such as pure spindle cell simulating a mesenchymal neoplasm, or if you have pleomorphic giant cells confusing you with anaplastic undifferentiated carcinoma. But look at the chromatin, still neuroendocrine. So in such cases, we recommend that you can consider sending the needle washout from FNA for calcitonin level to chemistry. Again, if it comes back significantly higher, next day, significantly higher than patient peripheral blood calcitonin, becomes diagnostic. Ki-67 grading, which is now recommended by WHO, I do not want people to start doing that on FNA samples. This is something which is only doable in histology. There's no use of doing Ki-67 grading in FNA of medullary thyroid carcinoma. So finally, anaplastic, we all know anaplastic undifferentiated carcinoma is a very easy malignant diagnosis, but confusions happen when you are trying to exclude metastasis to the thyroid, which is a major differential diagnosis in some oncologic centers. Maybe at Shaukat Khanum, it's metastasis to the thyroid could be more common than primary anaplastic carcinoma. So, for example, here is a melanoma. This patient had a history of malignant melanoma, and you can see the amazing similarity to anaplastic carcinomas because both are high-grade malignant tumors, and hence it raises the issue that every single time you're contemplating the diagnosis of anaplastic, you have to confirm by immunohistochemistry. We all know that they are so undifferentiated that they lose thyroglobulin, TTF1, very often even cytokeratin immunoreactivity. But one marker which is still positive in a very high percentage of cases is PAX8. So please try to stain it with PAX8 before labeling it anaplastic, because you might be dealing with a metastatic melanoma or metastatic renal cell or metastatic adenocarcinoma for lung, breast, and other primaries. We all know it has a very aggressive imaging finding, very heterogeneous with central necrosis. Often, even at the time of FNA, you will see extensive extrathyroidal extension with much significantly a large juxtaposed cervical lymph node. So these become important findings. And a significant change which has happened is that previously diagnosed entity of squamous cell carcinoma of the thyroid is out in the new WHO classification. Now it's regarded as a subtype of anaplastic carcinoma. So if I see the squamous cell carcinoma, like I'm showing here, my diagnosis will say anaplastic undifferentiated carcinoma of the thyroid, comma, squamous cell subtype. Either it could be squamous cell subtype, or it could be a metastatic or locally invasive squamous cell carcinoma, say from a laryngeal or oral primary. So important thing for us to realize. Very quickly, NIFP is a diagnosis which is based on histology. So if I have to answer two simple questions to you, is there a cytopathologic diagnostic criteria of NIFP? No, there is none. Should we be diagnosing NIFP as cytopathologist or FNA? And answer is very simple. No, we should never do that. The only important role that we could play is that all potential cases of NIFP, where we are suspecting that diagnosis, we put them in follicular neoplasm category so that they get a lobectomy and not over-treated by a total thyroidectomy. Because what we want to do is a very interesting term we use, is the de-escalation of treatment. Rather than total thyroidectomy, we want patient to undergo lobectomy, which will close the case. Patient doesn't need anything more if it turns out to be NIFP. So very quickly, in a couple of minutes, we all know that molecular tests form very important part of thyroid FNA, and there are many things which are happening now and in the future. And I may not have enough time to talk about artificial intelligence and computer-aided diagnosis, so I'll very quickly simply mention molecular testing. There is not only just emerging evidence, there is now established evidence that there is correlation between thyroid genomic tumor variants, their histology, their behavior, and what the outcome in the patients would be. So we not only use molecular testing for diagnostics, we often use now for prognostic and also for targeted treatment in the patient. We know that there are multiple tyrosine kinase inhibitors, which are now very commonly used in treatment of patients with thyroid cancer. If these patient-specific mutations like NTRK, fused thyroid cancer can be treated with the NTRK inhibitors. RET mutated thyroid cancers like medullary-thyroid carcinoma can be treated with RET inhibitors. So now we are getting into a completely new era of treating these thyroid cancers. And in terms of prognostic, these markers are included in the work of a thyroid patient when you do these commercially available molecular tests. For example, if you see TERT or ALK mutations, we all know that these patients will do poorly with a very high mortality, nodal metastasis, treatment failure, extrathyroid extension, so on and so forth. And these days, we all know that NTRK rearranged papillary carcinoma is a hot topic. These papillary thyroid carcinomas are often multifocal. They often involve cervical nodes at early stage of the disease. And sometimes they're harder to diagnose on cytology because they may not show very well-developed features of papillary carcinomas, and hence these molecular testing may demonstrate the NTRK fusion, gene fusion, and becomes very important. And just to let you know that more and more of these agents are now FDA approved in the US. Dabrafenib plus trametinib is now often used for anaplastic thyroid carcinoma treatment if it shows BRAF V600E mutation, and larotrectinib for NTRK gene fusion tumors, regardless of the cancer subtype. And a couple of years ago, pralsetinib was approved for RET mutated medullary thyroid carcinoma, and this list is growing. And hence the provision of molecular testing at any institution, including your institution, is very important to offer these the patients these targeted or personalized treatments if available. So with that, I end my presentation. I will be very happy to answer any question at this time. And I thank you so much for this opportunity to speak to you, something which I wanted to do for a very long time. And hopefully one of these days I could travel and do it in person as well. Thank you.
Okay, thank you very much, Dr. Ali. And I think this is an immense pleasure for us, for your presence and for your, this is a magnificent lecture. There are few questions. The first question is from Dr. Osman. Don't you think that removing category of suspicious for follicular neoplasm will result in excessive use of AUS?
It's an excellent question, Dr. Osman, and I thank you for asking it. There were some compromises which were made behind closed doors when we thought of single names. I have been using suspicious for follicular neoplasm at Hopkins since 2010. Ed Sebas, my friend and co-editor, has been using it at Harvard, Brigham. But this time when we convinced our group of getting rid of the term FLUS and getting rid of the term unsatisfactory, they asked us to get rid of the term suspicious of follicular neoplasm. So it's a compromise. Still prefer suspicious of follicular neoplasm, but in favor of a larger compromise, we gave up that term. But we would explicitly recommend adding the term that X percentage of cases, say 30% of the cases which are diagnosed as follicular neoplasm turn out to be benign hyperplastic nodules, or X percentage of cases diagnosed follicular neoplasm turn out to be follicular variant of papillary carcinoma or NIFT-B. So we will put a statement and we'll include it in the first chapter of our book. So I absolutely understand your concern. The major apprehension from people who were against the term suspicious of follicular neoplasm was that the moment you use the word suspicious in a diagnosis, clinicians often think it's suspicious for malignancy or suspicious of PTC or suspicious for some other malignant tumor. So I agree with you, but I think if you add that statement, you would be all right. You will not put those cases one category below in AUS.
Okay, any other question from audience? There is no question from the people who are online. So I think people have understood well each and everything in the thyroid.
So yeah, there are two things. Either I'm leaving everyone so confused that there are no questions, or I explained everything and there are no questions.
I think you have explained each and everything well. We're not right now, I think.
Okay, very good.
Okay, thank you very much. Once again, Dr. Ali, we are all elated, we are glad, we are very happy with this presentation and your presence here.
My pleasure. Thank you.
Okay, so we are in the last 45 minutes, and this is the last presentation of Pathology 2 session of this year's Symposium. So this lecture would be of Dr. Simon Payne, and he is currently working as consultant neuropathologist at Nottingham University Hospital NHS Trust. He is co-author of over 90 original and review articles, book chapters, and abstracts. Moreover, he is member of editorial board of neuropathology and applied neurobiology. He has many awards and distinctions like Jane Campbell Award, Royal College of Pathologists, Gold Search Medal. His today's presentation is about the neuropathological diagnosis of adult gliomas in 2022. Now over to Dr. Simon Payne.
Hello there, my name's Dr. Simon Payne and I'm a neuropathologist here in Nottingham, home of the fabled Robin Hood, and it is my pleasure today to be talking to you on the subject you see before you, the neuropathological diagnosis of adult gliomas in 2022. And this is a timely subject because, of course, in the last few months, last year or so, we have had a new classification, a new WHO classification published, and it makes a number of very significant changes to the way that we work, the way that we diagnose these tumors for our patients. And so what I'll do over the next 45 minutes is give you a general overview of the changes that have come along with this new classification, and to talk through the adult diffuse gliomas, the most common primary CNS tumors in adults. I'll mention very briefly ependymal tumors because they come under the term glioma, of course, and then spend the last few minutes just talking about some of the challenges that come with this new classification, which mandates molecular testing in a way that we haven't had to do before. And I'll talk about how we're hoping to solve these problems in Nottingham. So I think there'll be a time for questions at the end, but I'm happy to answer any online as we go along, if I can manage to log in to join you. So what does the new classification 2021 bring? Well, it's the latest point on a journey, which began with the first edition in 1979. The most recent was an update of the fourth edition, published in 2016. And as you can see, the interval between the updates has become shorter. And that really reflects the amazing advances that we've seen in our understanding of the biology of these tumors, and to a degree reflected in the way that they're treated. But I think one of the criticisms that the new classification is open to is that it is several steps ahead of where our oncological colleagues are. And I'm sure that that's the right thing to be doing, and that in due course, the oncologists will be able to catch up in a way. So I might have shown this slide last year, but what's the point of a pathologist? You might ask yourself. I know my colleagues ask me sometimes, well, it's really to predict the future. It's trying to determine what the future holds for a patient. And our tools for doing that, of course, are set out in the WHO classification, which in the past identified tumors principally on which normal tissue the tumor looked most like. And then a determination of grade comes from how closely that tumor resembles the normal tissue. And of course, there are lots of problems with this approach. And what's happened over the last few years is that our understanding of the molecular changes of brain tumors, and particularly the epigenetic changes, so not changes in the DNA sequence itself, but in the pattern of methyl and to a lesser degree acetyl groups associated with that string of DNA. And that's allowed us to predict the future in ways that we could not have imagined even just a few short years ago. And you can see on the bottom right here, this is a copy number variation plot generated from a methylation array. I'll talk a little bit about that as we go along. So this really is one of those papers that highlights why the microscopes, mine just here, I still use it all the time, of course, but why microscopes are not the be all and end all for diagnosing brain tumors. So if you were to take a group of tumors that look morphologically identical, but were to classify them on the basis of just two molecular changes, whether they had methylation of the promoter of MGMT, and whether or not they had homozygous deletion of CDKN2A or not, and to split them into these three different groups based on likely good, intermediate, and poor prognosis. And you can see with time that these molecular changes, for which there are no morphological correlates, are powerful predictors of patients' outcome. And so this is a much clearer crystal ball than my microscope could ever be. And secondly, we know that not only are there changes within a tumor type, that molecular changes that predict powerfully the future, we now have the methylation-based clustering of tumor types, and from this have emerged entities that we didn't even know existed. So there are a number of types of tumor here that the DGONC, diffuse glioneuronal tumor with oligodendroglial cells and nuclear clusters, which we didn't know existed. And likewise, things like the ependymomas, which I'll talk about in a little bit. There are types of tumor here that we didn't know were there, and that we can't discriminate from other entities on the basis of the microscopic appearances. So all of this has been a gradual change from the previous update to the current one. But as these changes have come in and been recognized, this consortium to inform molecular and practical approaches to CNS tumor taxonomy, for obvious reasons, C-Impact now, have published a number of papers which really have laid the groundwork for this new classification. So it's not so much a surprise, but it's a sort of more rubber stamping of what we thought was going to be coming. Now, there are some things to say about it. So in one of the papers published by the team, they describe the new classification and note that nearly all of these newly recognized types can be diagnosed on the basis of standard histological, immunohistochemical, and molecular analyses. Now, I find that rather amusing, but also slightly concerning that even if you've got the fullest available diagnostic armory, you might not be able to diagnose all these things. And that's certainly our practice, actually, our experience, is that even using the best available things that we've got access to at the moment, we still end up with tumors that we cannot give a clear answer for. And there's also a comment in the WHO classification itself that this is an intermediate stage to an even more precise classification. So just hold on to your hats. There's more to come in the future, and that there will be even more tumor entities coming. So I would recommend these references to you. Obviously, the Royal College in the UK is our gold standard for the way that we report these. And although this classification predates the WHO, it very much, on the basis of those C-Impact Now papers, predicts what's going to be coming. There's this fantastic summary in Neuro-Oncology by David Louis and co, which is a very nice, relatively easily digestible overview of the new classification. And then for those of you with a more clinical bent, there are these EANO guidelines to look through. And of course, the Blue Book website itself, where you can access all of this. And I'll show you some of the images from that as we go along. So there are lots of changes in the new classification. One of them is the introduction of a number of new tumor types. I won't go through all of these here. Some of them are, I think actually the majority of them are new names for things that we knew in the past, or perhaps a tidying up of some of the nomenclature. But there are some new things to this diffuse gliorenal tumor with oligodendroglial-like features and nuclear clusters I mentioned, and some provisional tumor types, including the cribriform neuroepithelial tumor. So there is a lot of change. There is a lot of change. And it's not just in terms of nomenclature, it's also in terms of grading. And so you can see here the changes of grade in the new classification. Some of this, again, is not a new change. It's not a change of grade as such, it's a tightening of the nomenclature. The one I would highlight in particular here, though, is the myxopapillary ependymoma, which is now CNS WHO grade 2. And one of the other things, finally, to mention about the new classification is that, of course, molecular changes are now, they now run through this absolutely in a way that they did not before. And some of these molecular changes are diagnostic. So, for example, obviously demonstrating an H3K27 mutation or similar, it's not always a mutation in these tumors, defines this diffuse midline glioma. But also, of course, many of these tumors possess molecular aberrations of one sort or another that are potentially targetable or actionable. So we are now testing for NTRK fusions, and as I'm sure you probably are and have been for some time, the BRAF mutations in a range of tumors as well. Now, in the UK, we have a national test directory for the genomic laboratories that should allow us to access most of these for any patients. I think that's fair to say there's a lot of regional variability in how that's applied in the UK, but the aim should be that if there is the chance of an actual mutation within a tumor type, then the patient sample ought to be tested for it. But as I said, the reality on the ground is a little bit different. Okay, so let's talk about grading, and this is an overview of the changes in grading in the new WHO. So the first thing to say is that grading is now within tumor type. And what that basically means is that we now have a name for a tumor. So let's talk about the IGH mutated astrocytoma. In the past, as I'm sure many of you will know, we had diffuse anaplastic and then glioblastoma. Well, those names have gone, apart from the glioblastoma, which I'll talk about. But we now no longer have diffuse astrocytoma, anaplastic astrocytoma. If it is an IGH mutant astrocytoma, then it is that's the name. That changes, that stays, sorry. The only thing that changes is its CNS WHO grade. So this could be a grade 2 tumor or a grade 3 or a grade 4 tumor. So the range of grades remains the same. It's that we've lost the name before astrocytoma. Second thing, which is perhaps rather more subtle, is that we have gone from Roman numerals to Arabic numbers, and that's because of it becomes clearer if we use figures 1, 2, 3 rather than the Roman numerals. And finally, in front of WHO grade, so in the past we would have put WHO grade 4, so glioblastoma brackets WHO grade 4. We now use CNS WHO grade, and that's really just trying to align the grading system for the CNS with that in the rest of the body. So a couple more things to note that we are still grading these tumors on their natural biology. So let's look at this example of a medulloblastoma, a grade 4 tumor. If it happens to be one of the molecular subtypes that shows Wnt activation, that's one of the defining features of a subtype of medulloblastoma, these tumors are particularly well treated. If you treat them, these patients survive basically. And so we are still calling this a grade 4 tumor rather than saying it's a Wnt activated medulloblastoma, but if it's treated, it has a very favorable outcome, which would correlate with grade 1, of course. So for the moment, and I suspect this will change perhaps in the future, or perhaps one more in the future, I don't know, classification, we're still grading these tumors according to their biology, not the post-treatment outcome. And finally, the thing I'd say is that it's combined histological and molecular grading. So we are still using morphological changes to define these tumors, but very, very often it is in addition to molecular changes. So I mentioned the H3K27 tumor, so it's a diffuse midline glioma, and as if you look in the WHO classification, it's a glioma that has to have this midline appearance, it has to have a particular morphology, and it has to have an aberration in this particular region. And similar sorts of things for the IDH mutated astrocytomas, as we'll talk about. And the way that we report these tumors is very similar to the previous classification, which introduced this integrated or layered reporting. So we combine a histological comment with WHO grade and molecular information. And the WHO authors note that this is typically manageable, but our experience, and we're behind many centers, is that you often end up with a very, very long list of molecular findings, and the practice is to put the technique used to determine the molecular change in brackets after it. So you can end up with really quite lengthy conclusions or final diagnoses. So this is an example of what that would look like from the paper by the WHO team. So the integrated diagnosis, diffuse low-grade glioma, MAP kinase pathway altered, subtype diffuse low-grade glioma, FGFR1 TKD duplicated. It looked like an oligodendroglioma. This tumor doesn't have a WHO grade associated with it at the moment. And then, as I said, the molecular finding and the technology used to determine it. And that's important because some technologies are better at doing some things than others, obviously. Now, this is all new, this use of suffixes. So if you have a diagnosis, well, let's go through this. If you're in a situation where it hasn't been possible to perform the molecular diagnostics that are needed, then the recommendation is to use this not otherwise specified suffix. So for example, in somebody perhaps over the age of 55, in whom you do not do any additional molecular techniques and diagnostic testing other than MGMT promoter methylation, it's certainly my practice to call these glioblastomas, NOS, CNS WHO grade 4. And what this is doing is signaling to the oncologist that either we haven't done the molecular testing, in that case because the yield would be very low, or because it's been done and has failed. But what it's telling the oncologist is that there could be more work to be done. This isn't necessarily a final answer. If there were clinical indications, clinical reasons to look further at this tumor, then we could do so. And that's separate from the second group of tumors in which we'd use the suffix NEC, not elsewhere classified. And this is used for tumors where we've done the testing, we've done the molecular testing, but there is a mismatch. The tumor doesn't fit either with a WHO category entity, or there's a mismatch between the clinical, histological, or immunohistochemical or molecular features. So a good example of this would be, for example, if you have an ependymoma, which is arising in the spinal compartment, but in the new WHO, as you'll see, the diagnosis includes the location. But say, for example, this is a tumor that arises in the spine, but the molecular techniques suggest that it's got a methylation profile, a profile of a tumor, perhaps in the posterior fossa or something similar. Then in that case, we would report it as an ependymoma, give a WHO grade if appropriate, and then use this NEC, not elsewhere classified label. And what this does is to flag up to the oncologist again that we've done an adequate workup, but that there is something odd about this tumor. It's not that we haven't done the test, there's something odd about it and it doesn't quite fit. And we find these very useful for identifying these tumors that are not typical. Okay, so yeah, this is the, I took this was taught by Professor Lewis, fantastic example of how to use this. As a traffic light system, a bit of a warning. Let's talk about the diffuse gliomas. And here there are major changes. There is a new division of the diffuse gliomas into adult and pediatric types. I won't mention the pediatric types. And I should say, by diffuse glioma, what I mean here is the tumors for which there is a diffuse growth pattern within the brain, not tumors that have, like a pilocytic, for example, that typically have a well circumscribed margin. Now, simplification of the classification is how it's described, and I think it probably is, but there is a very, very big change, and it affects every entity in this group, really. So this is these are the tumors that we're talking about. So as you can see, we've got the adult type diffuse gliomas, the astrocytoma IDH mutant, oligodendroglioma, and the glioblastoma, which by definition is an astrocytoma that lacks evidence of an IDH mutation. And these are split apart from the diffuse pediatric low-grade tumors, the pediatric diffuse high-grade gliomas, and then the circumscribed astrocytic gliomas, which, of course, pilocytic is the best example. So is this really simpler? Well, let's have a look. This is the 2016 classification. And as you can see, there are lots of names here. Okay, we all understand what these are. And this is the new classification. Now, some of these, the diffuse midline, for example, is moved into the pediatric realm. But actually, I think it is a little bit simpler. That is not reflected, however, in the testing that is needed to identify these different tumors. So I'll go through these in detail, but basically we have the oligodendrogliomas, for which the defining feature is this loss of 1p19q. And of course, the oligodendrogliomas will be IDH mutated. There are other molecular changes in this group, which I'll talk about as we go through them. The second type of tumors in this group are the astrocytomas that possess an IDH mutation. Many of these will also show loss of ATRX, but then there are important molecular changes that now define the grade of these tumors, in addition to morphological changes as well. And I'll talk through those as we go along. And then the final group that I'll talk about is the glioblastoma now, which is by definition an astrocytoma, as I mentioned, that lacks evidence of an IDH1 or 2 mutation. These will typically show retention of ATRX, excuse me, nuclear ATRX. And they also have molecular changes that define them, as we'll talk about. So here they are, the astrocytoma, IDH mutant, the oligodendroglioma, IDH mutant, which of course is 1p19q co-deleted, and then the glioblastoma, IDH wild type. So the first of these. So as I said earlier in the talk, these no longer have diffuse or anaplastic names in front of them, and the grade 4 astrocytoma that is IDH mutated is an astrocytoma, IDH mutant, CNS WHO grade 4. It is no longer a glioblastoma. And these are the definitions taken from the WHO, and they're broadly similar to previous in terms of morphology. So if you have microvascular proliferation or necrosis, then it is a grade 4 tumor. If you have significant mitotic activity, then it's a grade 3 tumor. Now, what changes is that the presence of homozygous deletion of CDKN2A and or CDKN2B is enough to warrant CNS WHO grade 4. So you can have a tumor that would looks like in old money diffuse astrocytoma, IDH mutated. But if it's got this molecular changes, then that by definition means it's a grade 4 tumor. And this is that same information in pictorial form to highlight the fact that a homozygous deletion wins grade 4. Now this comes from a paper by I think a London group just before the WHO classification came out, and at that point we still had the old terminology. But if you were to just replace that word with glioblastoma with astrocytoma, then all of this would stand for the latest WHO. And here we go. That's the label at the bottom. That's the previous nomenclature. So that presence of the homozygous co-deletion, so homozygous deletion of CDKN2A/B in the presence of an IDH1 mutation is sufficient to make this grade 4 tumor. The oligodendrogliomas are perhaps more straightforward. Not much has changed here other than the fact that we've lost the anaplastic and the fact that it's worth noting that you can find, or typically you'll find TERT mutations in these tumors. And there's a note in the WHO to suggest that the presence of CDKN2A homozygous deletion may serve as a marker of a more aggressive tumor, a grade 3 tumor. So it is key when you're obviously diagnosing these to establish there is loss of 1p19q, either by FISH or by some other method. And I've just mentioned here that the WHO doesn't typically specify a technique for analysis of molecular change. They leave that to the pathologist. And finally, the glioblastoma. Well, this is a diffuse astrocytoma in which we have one or more of these findings. So we'll be familiar with the microvascular proliferation and necrosis. Of course, this is an IDH wild type tumor, but the presence of one or other of these molecular changes alone in the context of a diffuse astrocytoma is sufficient to warrant this title, this definition. So finding a TERT promoter mutation, an EGFR mutation, or what we typically see is gain of 7, loss of 10 on the copy number plots is enough to make this a grade 4 glioblastoma. And it's commented that this DNA methylation profile, which I talked about last year, is key here, or is desirable, but as you'll see, it's key to many of these diagnoses. And this really highlights the issues that we see. So this is a tumor that is IDH wild type. Obviously, the morphology here looks much more benign than this, which looks frankly malignant. These are both IDH wild type tumors, but both of them on the copy number plot show that there's gain of chromosome 7, loss of chromosome 10, gain of 7, loss of 10. And that alone is sufficient to mean that both of these tumors are glioblastoma. CNS WHO grade 4, a big change. And we see this clinically. We have patients who have a small biopsy, perhaps of a diffuse process, very low grade looking on the radiology, but we managed to demonstrate these findings on the molecular analyses, and it means that this patient has aggressive therapy. It's taking a little bit of adjusting of our oncology and MDT colleagues to get used to this, but this is the way that we're now working. So just to go through that again, so the oligodendrogliomas defined by 1p19q, the IDH mutant astrocytomas, the presence or absence of this CDKN2A2B is really crucial to determining grade. Irrespective of how it looks morphologically, the presence of this CDKN2AB homozygous deletion is sufficient to warrant WHO grade 4. Alternatively, in the absence of that, it's necrosis and or microvascular proliferation. And in the glioblastoma, it is, of course, necrosis and or microvascular proliferation, but any of these molecular changes, TERT mutation, EGFR amplification, or gain of 7, loss of chromosome 10, sufficient to define this tumor as a grade 4 tumor. Okay, so I just mentioned briefly the ependymomas. This is a cluster diagram from the on the basis of methylation classification, and what you'll see is that tumors come out not just as specific tumor types, subependymoma, ependymoma, etc., but that they come out also based on location. So posterior fossa, there are 2 types, A and B. I won't talk about in this talk due to it would take me too long, but it'd be lovely to talk about that perhaps another time. So there are distinct tumor entities based on the compartment within the nervous system that they arise in. So very briefly, the journey to where we are started a long time ago in terms of ependymoma biology. And with that, that reflects the changes in nomenclature that we've seen. So 3rd and 4th, and then the update were rather similar. We had subependymomas, mixed epipillary ependymomas, grade 1, of course, using Roman numerals. We had these morphological subtypes of ependymoma. In 2016, we were introduced to the relar fused, now no longer relar fused, I'll mention, it's ZFTA and the anaplastic ependymomas. And now what we have is a very different looking classification that has supratentorial ependymomas. It has the posterior fossa ependymomas. It has spinal ependymomas, and the mixed epipillary ependymoma, which is now WHO grade 2. So for the supratentorial ependymomas, they can be either grades 2 or 3. For many of these, the grading isn't defined, as I'll talk about, but we've got these now molecularly defined types of subtypes of ependymoma. And so what's changed? Well, we've lost the terms ependymoma and anaplastic ependymoma. They no longer exist. They are now qualified by the anatomic location, so supratentorial ependymoma, etc., as we've just seen. We've also lost the tanocytic, clear cell, and papillary subtypes because they were deemed to not have clinical significance. And as I mentioned, we've got molecularly defined tumor types, ZFTA now no longer, rather than relar fused. And as I mentioned, the mixed epipillary ependymoma is now CNS WHO grade 2, reflecting the biology of many of those tumors. So the grading of ependymomas is still very much a work in progress. Looking through the WHO, it's still very poorly defined as to what grade is and as to how useful it is. There's an invitation to grade these tumors as we have done previously, which is basically on the presence of significant mitotic activity, but it's going to take more work to iron out clear definitions of what each of these grades is and whether they are actually useful or not. What's much more useful is to identify the molecular subtype of these, because that's powerfully predictive. So, excuse me, I will just mention group A and B posterior fossa tumors. The PFA group A ependymomas are much less favorable than the group B. And one of the tumors that's emerged from the methylation analysis is that the spinal ependymoma with a MYC amplification is a very aggressive tumor as well. So molecules really are key to determining the future for these patients. Okay, so in the last 10, 15 minutes or so, what I talk about is what we're doing in Nottingham in order to solve the problem of molecular diagnostics. Now, as I've mentioned through a lot of this, methylation analysis is key. So what we do with this is the DNA wrapped around histones and so on, and it's got these methyl groups attached to it. And what we've been able to do, based on some amazing work done by the group in Heidelberg, is to classify tumors on the basis of the methylation fingerprint. And the way that that's been done almost universally until very recently is using, excuse me, Illumina EPIC arrays, so microarray technology, to identify the changes in the 850,000 or so regions of the genome where there is often hypermethylation, CPG islands. And this technique is incredibly powerful. Essentially, we have a reference cohort of tumors. We put our methylation pattern into that reference cohort, and using some amazing maths, you then get a calibration score as to what sort of tumor it is, which group it matches, and the probability of a match. So a match of, or a classification's calibrated score of 0.99 is very high, whereas 0.3 is you basically ignore it. And what that's shown is that the methylation array is better than us as pathologists. So these are initial pathological diagnoses. These are the methylation diagnoses on the right. And where there's a gray line, it means the WHO grade's unchanged. Where there's a blue line, it means it's been downgraded. And where there's a red line, it means it's upgraded. And you can see that most of these are either blue or red. So there are some gray lines, but most of these are blue or red, meaning that the diagnosis has been significantly changed on the basis of methylation array analysis. And this runs central through the WHO, as I've also already mentioned, and that's where things like the dugong have come from. So, are there other uses to this technology? Well, this is a fantastic paper from a group in Norway who analyzed the methylation pattern of tumors intraoperatively. And I mentioned earlier this Wnt-driven medulloblastoma. Well, here's a patient whose tumor is in the posterior fossa, where, of course, these tumors tend to arise, or always arise, and they have left some of the tumor here. And they've done that because taking that tumor would risk damaging the child and leaving them with cerebellum mutism, which is a really dreadful position to be in. Patients are unable to speak, they have problems with swallowing and so on. But they were able to leave that tumor because they were able intraoperatively to classify it with confidence as a Wnt-driven medulloblastoma, because they knew that this tumor would respond to chemoradiotherapy. And so if this is absolutely game-changing for pediatric oncology in particular. Now, this is some slightly older data, but it's looking at the turnaround times for our molecular results from our provider. And as you can see, they're nowhere near intraoperative. They're tens of days. And this is a big problem for us, because it means that we're not able to obviously help intraoperative management. It means that patients have weeks of uncertainty waiting for a diagnosis. You know, it could be a grade 2 looking astrocytoma, IDH mutated astrocytoma, but we can't tell with the microscope whether there's a CDKN2AB mutation, homozygous deletions. We have to wait. It means that patients are left potentially untreated, overtreated, or treated with the wrong thing. It's really very unsatisfactory to have these long turnaround times for our methylation and other molecular analyses. And so that's led us to look at something called octave nanopore technology, or ONT. which you may or may not be familiar with, but basically we had it's next generation sequencing. So we had the initial Sanger type sequencing, first generation. We've then got the high throughput next generation sequencing, so the Iron Torrent, etc., the Illumina sequencing platforms. And we're now able to use these amazing third generation technologies. And the thing that is absolutely key about these is that they sequence the native DNA, so the actual tumor DNA, not tumor DNA that's then been amplified, PCR'd, etc. And the other thing about them is that they generate massively long reads. The sequences that these things can read are much longer, which means that you have a much higher confidence in your analyses when you've got multiple layers of reading. And this is, I thought I'd just show this lovely video of how the nanopore works. So what you have is the DNA, the native DNA, whizzing through, here it goes, to this pore. And as the A's, T's, G's, C's, etc. come through, there's a change in amplitude, a change in the current across this pore. And based on that, which is also methylation dependent, you can sequence the DNA on this tiny, tiny current changes. It really is fantastic technology. So here it is. This is our raw data, straight from the pore, the changes in current. You put in some bioinformatics to call the different nucleotides, and then you analyze that data. And this has got tremendous advantages over the current standard, which is the next generation sequencing, or even the EPIC array. So we don't have any amplifications. There's no bias towards more prevalent species. It's much quicker, and you can do the analysis in real time with these massive read lengths. And when we're thinking about comparing it to the EPIC array is very expensive. The machine itself is very expensive. And you have to batch samples and so on. And none of those are issues with the nanopore. So these are what the actual platforms look like. This is the smaller MinION. This is hopefully what we'll be buying very shortly, a GridION to a much, much bigger PromethION. And it's got a standard pipeline of analysis, so data acquisition, you quality control your data, you do your alignment, classification, etc. Then into the secondary data analysis where you're looking for nucleotide variants, etc., and coming out with a report that we can then integrate into our with our morphology. And the fantastic thing about this, well, one of the many fantastic things about this, is that you can do this in real time. So when you look at the software, you can see in real time, these are the individual pores that are represented here, and you can see whether they're active, inactive, how the sequence is going, and you can see how the read length compares across the different pores. It's absolutely fantastic. Now in Nottingham, we're very fortunate to have Matt Lewis and Alex Payne and colleagues who've developed some incredible technology here that I won't go into detail, but this data, this software that they've generated allows you to target your sequencing. So if you're targeting, say, for example, the first 8 chromosomes, you can just sequence those. And if the sequence as it comes through in real time looks as though it's from one of the other chromosomes, that sequence is rejected from the pore. So you get much higher coverage of your regions of interest. And they, working with the Heidelberg group, have demonstrated in this fantastic paper that I recommend everyone should read. They've shown that the nanopore-based analysis is comprehensive. You can do everything that you need to on it. So clinically relevant single nucleotide variants, copy number alterations, target gene methylations, the MGMT promoter for us, and also this fantastically powerful methylation classification I've talked so much about. Again, I won't go through this in detail in the interest of time, but they have shown that the accuracy of the array, of the nanopore-based technology versus the array, current standard of practice is very, very good. They are comparable, which is fantastic news. And this is the output of the Heidelberg's pipeline, which is to give you a list of the mutations. It gives you prediction of methylation status, the MGMT promoter. Gives you copy number, so we can see it's the glioblastoma, and here we've got that gain of 7, loss of 10, and also the prediction as to which sort of tumor it is based on methylation-based classification. So it really is in one page all you could have wished for, or I could wish for, in terms of molecular diagnosis. And this is that paper that I showed you, that Wnt-driven medulloblastoma, the intraoperative analysis. And we're hoping to be able to do this in the medium term. I think here we're hoping to get the methylation analysis up and running soon in the new year, and then we'll hope to move towards an intraoperative analysis in due course. And it's worth saying, so I know many of you won't be neuropathologists, but based on nanopore, there is a paper in transgenetics which shows how you could use this nanopore technology to do basically all heme-oncology in one machine. It's absolutely incredible. And again, here's a paper that's worth reading on the methylation classifiers, both for brain tumors, and they're also being increasingly used for sarcomas. So my time is up, and just to say, what we've gone through is an overview of the changes to WHO classification, particularly in the diffuse gliomas in adults. There are lots of changes, and as you'll have seen, the incorporation of molecular data into the definitions of many tumors, including those most common ones, really means that you have to have optimized molecular testing now, which is a primary diagnostic tool, not an add-on or adjunct to morphology. It really is, it is rivaling our microscopes for supremacy. I've mentioned this Oxford nanopore technology, which I think is the most promising of the different platforms available, and what we hope to be introducing very soon here in Nottingham for our brain tumor patients, which in due course we hope will be able to alter or influence the intraoperative management. So that's my talk. I'll be pleased to take any questions in the session to follow. Thank you.
Okay, thank you very much, Dr. Simon. I think this is the one of magnificent lectures, and as well a very difficult one, as far as my knowledge for CNS tumor is concerned. You have appropriately answered all the questions that have been sent by only one person, I think, who is the only person who knows in this square what is the neuropathology in the tumors. Okay, so there is no question left, and there is no question from the people who are online and in the audience who are sitting here. I don't think so that they have any question, but again, we thank you again from my institution, from this whole symposium, and thank you very much for your presence and for this magnificent informative talk.
My pleasure. Thank you very much.
Thank you. Thank you very much. So with this last lecture, so this was the end of this year's symposium as far as the pathology sessions are concerned, but the symposium will go on for next 2 days. And I like to thank all the audience who are sitting here, because they are not in their comfort zone, and the other people who are online. Of course, you guys are the true essence of this whole academic activity. And I like to thank Anika and the whole IT team, because they are the persons, they are the real person who are working behind the closed doors, and all the speakers. And moreover, and as always, Dr. Sajid Mushtaq and Usman Hassan, who helped me in selecting all these speakers. And the last thing is that our auspicious institution, that the people who are working at the top, at the helm, I think this is their sport, which is basically making every symposium a success story. So thank you very much from my side, and maybe I see you next year. Thank you very much.